will start with a case presentation like we all have done. 72-year-old gentleman, hypertension, hyperlipidemic, smoker, presents with a non-STEMI. EF was 55%, and this was, so as you can see, there's a very tight distal left main into the circumflex on the left anterior descending. This was a sort of a non-selective shot, but other shots show that the right had some mild disease in the mid. And there was a mid-LED lesion, and obviously the significant left main. Just a show of hands. Anyone would do this? No one in this room would do medical, right? Anyone surgery? Yeah, I agree. I would do surgery too. And PCI up front? Anyone? Oh, we have one of the cowboys in the back. You would just do it. Okay. You know, honestly, if it was my father or me, I would probably err towards surgery, at least as a first option. We have 40 plus years experience with limas, and with a lima, I know what I'm going to get. With left main stenting, there's still debate on how to do it. I mean, but patient preference matters. Informed consent matters. If you tell a patient, well, either they can cut open your chest with a saw and you'll be in the hospital for 7 days, or I can go through the radial and be done and you'll be home tomorrow morning, that is not informed consent. So having a heart team approach and approaching the patient with the belief that he or she can make the right decision is what is really, really important. And this multidisciplinary cardiovascular team approach is different than our paradigm in 2022, and different from our old paradigm, which had the interventionist in his or her silo, the cardiologist in his or her silo, and the surgeon in his or her silo. But now we are together as one dysfunctional family, and it is important. So surgery, I think, is clearly better. We have 40 years experience with limas, and I'm talking to interventionalists, and don't throw tomatoes at me, but I believe that that is probably the best option for this patient, assuming no other comorbidities or something else. Now, whether that is bypass, multivessel stenting, like Samir talked about with MCS, or multivessel stenting staged, possibly a hybrid approach, which was a technique that really has not caught any steam at all, which I was expecting, a lima to the LAD and then fixing the circumflex. That has not really got any traction, at least not in the United States. We have used it a few times, but very, very rarely. So we have to go away from I can fix anything mentality, because Samir showed it. Putting a stent in the left main is not that difficult. DK crush, technical, but not difficult. We can probably stent almost everything. The question remains, is it the right thing to do? This gentleman absolutely 100% said, hell no, I'm not going to have surgery. I will either go home and die, or if you don't put a stent in me, I'm done. And so, after we had discussed with him and his family, had the surgeon, all of us in a room, we decided to go ahead. We did do MCS, Samir. I don't know if you like it or not, but in this situation, we did do MCS. And imaged everything. If you don't image a left main, I think it's malpractice. Because if you're putting a stent in the left main, making sure you well oppose that stent, make sure you pot the proximal area, it is not a question, it is a necessity. Long story short, we got a terrific result, came out very well, patient went home, did great. Not difficult, we did it. Patient is still alive, doing very, very well. For me, it's all about location, location, location. You see a left main disease, if it's distal, it's surgery as a first option. I will tell the patient, I believe that you should have surgery because I think that is the right thing to do. If it's a mid-shaft lesion, I will tell the patient, I'm going to talk to the surgeon, but I can do this, I think, equally well, maybe if not better, in terms of long-term morbidity. If it's an osteal lesion, I risk stratify that patient based on the syntax score and other issues, and then decide how to proceed. So this is my way of doing it. I'm not saying it's the right way, it's my way of doing it. Now we know that the MACE levels, and I don't want to rehash data, but left main disease, low syntax score, you can basically go either way, depending on location. Intermediate scores or high scores. High scores, I think, if you have a high syntax score, I believe that I know that surgery is better, even with first generation stents. And that is why we've had so many advances in evaluation and therapeutics, that I think the data coming out is already antiquated. As soon as the data is published, it is really dated, so to speak. And because we have to evaluate our lesions beyond the oculostenotic reflex using physiology, imaging. Like I said last night in my talk, imaging is not just pre, because that is not the right thing to do. Imaging is pre, during, and post, especially post-stenting. The importance of the advances we've seen now and the importance of complete revascularization with our advances in CTO therapies has been really instrumental in sort of closing that gap. Lesion prep prior to stenting. Don't primary stent these left mains. Make sure you prep them. They're probably more fibrotic, more calcified than you think they are. We have terrific new niche technologies that we can use. IVL just came into the United States a few months ago. I know you've had it here in India for a few years. We now have better stents, and we have aggressive OMT. You can never forget the OMT. Medical therapy is what improves survival. And so, honestly, I believe that the studies become dated as soon as they're released. Because by the time they're released, we have a new technology, a new technique. China produces some other technology, technique for left main stenting. So, but the problem is, the beauty now is, the size does not matter. We have a seat at that table. As an interventionalist, the surgeon was essentially the only one who really talked to that patient. Whether we're Yoda or Darth Vader, we have a seat at that table, and we need to have a informed, honest discussion with the patient, not a biased discussion. The recommendations for left main revascularization are a little bit different from the US and in England. In terms of low syntax score, it's still a 2A indication. It's a 2B for intermediate. Wow, time has flown by. Heart team approach. I believe that you favor CABG with low EFs, concomitant cardiac surgery like AS, doubtful adherence to DAPT, diabetics with multivessel disease. Favor PCI in terms of urgent revascularization, reduced life expectancy, serious comorbidities. Don't forget the patient preference. That does play a role as long as they have it. We have a lot of options available to us. Imaging is the foundation of left main stenting. LV support is an option. The 7 French guide really has played a huge role in my practice. Volume drives outcomes. If you don't do left main stenting, don't do left main stenting. You must have a colleague, you must have another person, you must have someone else nearby. Ego should be taken out the window, and you should pass it off to your colleagues. Location plays a role, and you have to be comfortable. You must IVUS these patients. The gap between PCI and CABG, I think, has narrowed over time as we've had neurodegeneration stenting and improved optimal medical therapy. I'm going to bypass this in the interest of time. But we have two very different procedures here. And you must understand that patient preference matters. I am done. The proper way to perform left main bifurcation stenting is still to be debated. I thank you for your time.